IVF-отделения медицинского центра «Альтернатива», Львов, Украина, одного из представителей нашей ассоциации ВШР. Прошу, Любовь.
Thank you, and first of all, I would like to express my deep gratitude for the main sponsor of our meeting, the company Merck, for their kind invitation, and with the great pleasure I want to present you a new stratification of low responders to ovarian stimulation. So, the first description of a patient who demonstrated decreased follicular response to ovarian stimulation with the few oocytes retrieved was reported for the first time in this study 34 years ago. So, and since then probably several hundreds of publications have been published on literature, but the main problem of all of this study was the heterogeneity on the definition of this population. Why it is so important? Because thus we are not able to identify the use of any particular intervention to improve treatment outcomes. So probably Bologna criteria was the first step toward to uniform the definition of this cohort of patients, and I'm sure that you are all familiar with this study. I will just shortly remind that the poor responder was characterized by the presence of 2 out of 3 features shown here. So one of them is advanced maternal age. The next one is the one episode of poor ovarian response with less than 3 oocytes retrieved and abnormal low ovarian reserve. According to Bologna criteria, the poor responder might be any patient with at least 2 episodes of poor ovarian response with 3 and less oocytes retrieved. So, the Bologna criteria was mainly designed to select homogeneous population of patients based on oocyte quantity. So what do we know about oocyte quantity and how does it predict the live birth rate? So we have the first question to Bologna criteria: what the number of oocytes will characterize patient as poor responder? So have it to be 3 as it's written in Bologna criteria, or it might be more. So this slide, Professor represented us, and I will just repeat it. So, as you see, this is famous Shankara study showed us that the number of oocytes have a strong correlation with the live birth rate, and we have a strong scientific evidence to divide patients into 3 groups. So, poor responders with the 3 and less oocytes retrieved, our responders who have probably more than 15 oocytes retrieved, and categorization of patients as normal responders is usually based on exclusion of poor and over responders. So does it mean that normal responders will be homogeneous population with 4 and up to 15 oocytes yield? And this is very interesting next study, just recently published, and the authors of this study, Dracopoulos and Polisius, decided to divide this just mentioned population of women with 4-15 oocytes yield into 2 subgroups. The one of them, something is happening wrong? Okay, so one of them with the 4-9 oocytes yield, and the next one is 10-15 oocytes retrieved. So, and what is interesting shown here, that we have a statistically significant difference in the means of live birth rate between the suboptimal and normal responders. So it might be very useful approach to identify additional subgroup of population with 4-9 oocytes retrieved in order to maximize treatment outcomes. What is very interesting issue that according to current literature, this is a very large population of IVF patients. So according to HFEA data, they represent 43% of all IVF population. That is why this group of patients cannot be overlooked now, and Even according to current literature, it is fully justified to call some patient with 4-9 oocytes retrieved as suboptimal responders. But who is this population of suboptimal responders? So genetical variation is probably the main explanation of reduced ovarian sensitivity to gonadotropin administration, and few research groups have examined the effect of the different types of single nucleotide polymorphisms, different of mutations of LH-FSH molecule and FSH-LH receptor, and they showed that a specific single nucleotide polymorphism and specific mutations are responsible for the altered ovarian response to gonadotropin administration. And very interestingly, that they concluded that most of these patients will benefit from LH supplementation rather than from stimulation with a higher dosage of FSH. Why, we will discuss later. So, as we realize that the sensitivity to gonadotropins can be different among the IVF population, it was proposed to calculate so-called follicular output rate, FORT. So it is a kind of responsiveness of antral follicles to FSH, and the FORT is calculated as a ratio of pre-ovulatory follicle count to antral follicle count in baseline. And our patients can be divided into two different groups. One with a high FORT of 70% and another with a low FORT with 30%. Why it is so important to identify those patients with low FORT? Because they can belong to a few ovarian response group where improvement of their treatment might be not so difficult approach. So take into account a previous stimulation that we have got a few oocytes with a good ovarian reserve. So adoption of more potent protocol is looking not so difficult approach. It can maximize treatment outcomes. So take into account mentioned above, we have a next question to Bologna criteria. Are those women with poor ovarian response are homogeneous according to the sensitivity of ovaries to gonadotropins? So if you will look on this slide, you will see two young women up to 35 years old, but one have a low ovarian reserve and with one episode of poor ovarian response. The next one has a normal ovarian reserve, but with two episodes of poor ovarian response. So according to the Bologna criteria, those two patients are identical, but we do realize that not, because if we would prescribe for this, for the kind of patient with the normal ovarian reserve and with one episode of previous poor response, a higher dosage of FSH and LH. So this patient would benefit from it, but we would have no use of higher prescription gonadotropins to the patient with low ovarian reserve. So existing Bologna criteria are not able to discriminate patients with low ovarian reserve and with low ovarian sensitivity to the gonadotropins because of inherited resistance. So the next question to Bologna criteria is, are those women with the poor ovarian reserve are homogeneous according to the oocyte quality? And again, what do you see here? That according to Bologna criteria, this old patient, 40 years and older, and these two young ladies are equal again, but we do realize that they are not, because the quality of oocytes will be different, and that is a huge difference between those three groups of patients. As we realize that with the three, next please, with the three oocytes at 40 years old, we will have the probable live birth rate near 4-6%, but with the same number of oocytes, like 3 at the patients less than 35 years old, this probable live birth rate will be near 20. So we do realize that existing Bologna criteria comprise very heterogeneous population of patients, and what is also important that the authors of Bologna criteria do not offer some clinical advices how we have to manage those patients. That is why, in order to improve the treatment outcomes by very outstanding and well-known for us scientists, most of them you can see here on the picture, it was proposed to change, next, the definition of poor ovarian responders to, which is based on the combination of very heterogeneous criteria, to low prognosis patients. And in brief, 4 groups have been suggested based not only on the quantitative parameters, but on the qualitative parameters like age and expected euploidy rate. So as you see here, 4 subgroups of patients have been suggested. The first group of patients included young women less than 35 years old with normal ovarian reserve but with unexpected poor ovarian response with less than 4 oocytes retrieved and unexpected suboptimal response with 4-9 oocytes retrieved. The second group included patients older but with the same reduced sensitivity to gonadotropin administration. The third group included young women up to 35 years old but with a low ovarian reserve. And the fourth group included old women with the low ovarian reserve. So as you see here, these 4 groups are very different, and each of these groups has its own degree of low prognosis. So probably the lowest degree of low prognosis will be in the first group, and the highest degree will be on the fourth group. The Poseidon group also introduced to us a new measure, new marker of successful IVF outcome, and this measure is 1 euploid embryo available for the transfer. So we all would agree that it is a very important endpoint for all of us. So how does it work? So if we will meet a patient 36 years old, so we will need probably at least 11 oocytes to get at least 1 euploid embryo available for the transfer. Because according to the statistics, probably 8 of these oocytes will undergo fertilization, and we will have at least 5 embryos of the first day development with 2 pronuclei, and we will have at the end 2 blastocysts, and according to the statistic we will have 1 euploid embryo for the transfer. We also know that the transfer of euploid embryo eliminates age-related decrease in implantation, but we also know that, and we realize now that each of suggested 4 groups will need different approaches to get this marker of successful implantation euploid embryo. So to better understand what each of these groups needs, we need to realize what kind of patient it includes. So as you see, the first group included young normal gonadotropic patients with good AMH, good androgen follicle count, but they have probably the genetic variations in this population of patients, and they will show us a high consumption of gonadotropins, and they will show us a low FORT and lower pregnancy rates. So if we will meet this kind of patient, and if we will recognize this patient on the 5th or 8th day of controlled ovarian stimulation, so administration of recombinant LH is an effective approach in order to rescue oocyte and embryo competence. And few studies have demonstrated, next please, they compared the strategy of increased FSH administration and the strategy of LH implementation, and they showed us that addition of LH from the day 7-10 is more efficient procedure in rescuing oocyte number and competence. And why so? Because we remember 2-cell gonadotropin theory, showing us that LH through the androgen production improves granulosa sensitivity to FSH, thus it increased the number of FSH receptors. So LH and FSH, they act synergistically. And can we come back 2 slides back? So, and if we are able to, if we meet this patient of the first Poseidon group for the second time, so we see the patient with low fort, with good ovarian reserve, so the best strategy would be for such type of patient to increase the dosage of FSH and to add LH from the very beginning, from the first day of stimulation. Let's talk now about the second group. So the main difference of this group comparing with previous one is the lower oocyte quality because of age. All of us know that the oocyte quality depends mainly from the granulosa cells which surround oocyte and nourish oocyte. And for many years it had been shown that insulin-like growth factor is the major player in oocyte quality. We know that granulosa cells can be adversely affected by the oxidative stress in aged women, resulting in decreased proliferation of granulosa cells and increased level of apoptosis. So insulin-like growth factor improves all of these issues, and just recently it was shown that testosterone and androgens can improve oocyte quality because it has very interesting action which had been recently shown that it increases insulin-like growth factor production on liver. In a such way it improves oocyte quality and competence. But we do remember very well that LH can induct the androgen synthesis in the TICA cells. In a such way it acts synergistically with the insulin-like growth factor, and that is why we get higher quality of oocytes and better embryo quality. That is why it is not a surprise for us that there are a large number of studies in literature confirming that, and LH, as we see from the Ernesto Bosch study from 2011, that LH can be effective in increasing oocyte embryo quantity and competence. We have also the meta-analysis of Hill showing the same and very large Lehert study from 2014 showing, next please. This study, which is also, all of you probably know that prescribing of LH can improve the success rate on 30%, and this approach gives us at least for one more oocyte. So we were talking just now about higher dosage of FSH which can be administered and the addition of LH. And someone can ask now whether such type of strategy can have a negative impact on the oocyte competence and embryo quality. And I do remember very well the ASH of 2012 and 2013, and both Carlo Alvigi and represented Carlo Alvigi now in the Poseidon group, as you have seen in the slide. So they introduced us a new strategy of mild stimulation, suggesting that the lower dosage of gonadotropins can increase oocyte competence and quality. But we do realize that a lot of things have changed in this time, and we see that very wide implementation of PGS now, so we can understand more. And you already have seen this slide today showing that with the increasing of number of oocytes and blastocysts, the haploidy rate probably does not differ. So maybe in a specific group of patients like Poseidon group 1 and Poseidon group 2, the elevation of the elevated FSH administration and LH addition from the beginning of the stimulation has some evidence-based beneficial effect. So let's talk now about the groups 3 and 4. Those two groups have something very common and something very different. The common thing is that both of these groups have a low ovarian reserve and a high fort, and most of Bologna patients will fall into these groups. Let's talk first about the third group. So as we realize that there are young patients with a good androgen production, so probably they would not benefit from LH, and increasing of FSH would not also bring us any benefit because they have a high fort. But we are still looking to get enough number of oocytes. According to Poseidon calculator, to get at least one euploid embryo at this category of patient, we will need probably 6-8 oocytes. But what we can do if they have such a low AMH and low antral follicle count? So this is a very interesting study, was also published recently, 2016 in Fertility Sterility Journal, and again Filippo Maria Ubaldi and Carlo Alvigio are the authors of this study. So this study is based on the conception of the presence of few waves of folliculogenesis within one menstrual cycle. So this conception was shown for the first time on the animal models that it works, and later it was proven on humans that we can have even 2-3 waves of folliculogenesis in one menstrual cycle. And in this study they showed that they stimulated patients both in follicular phase and luteal phase. So they started the stimulation from the second day of the period with the fixed dosage of FSH and LLH. They prevented LH surge with the GnRH antagonist, and they triggered them with the GnRH agonist. The second stimulation was started on the 5th day after the previous egg retrieval with the identical protocol. And what they did show us, so here you see a detailed comparative analysis of the first follicular stimulation and the second luteal stimulation, and it revealed no difference in the FSH consumption, in length of stimulation, and even no difference in number of oocytes retrieved. But in this study it was shown that the luteal phase increased the ratio of patients with at least one euploid embryo available for the transfer. And months ago, Filippo Maria Ubaldi on XMED meeting presented orally his new data. He told us that probably he sees that the number of mature oocytes will be more in the second luteal phase stimulation. So that is really very interesting approach for this type of patients. Let's talk about the fourth group. So this group would have the highest degree of low prognosis, and still the intervention of improvement are under evaluation, but we do realize that these population are aged women with low androgen production, so maybe adding of recombinant LH can increase live birth rate, and we see it on the some randomized control trials. What is about the androgens? So the Cochrane database was updated recently, and it showed that androgens like DHEA and testosterone may increase the live birth rate in such type of patients. And frankly speaking, I'm looking for maybe new studies with the use of growth hormone, because all previous studies showed that there is no beneficial effect of it. But let's remind that it was very heterogeneous population of poor responders, so maybe it would be useful to examine the effect of growth hormone in this homogeneous population of patients, because growth hormone have very interesting influence. He also increases insulin-like growth factor 1 production in liver. And just very few words with the patients of maybe very high degree of low prognosis, and different types of approaches have been discussed in the literature for last years, like method in vitro activation. So it is very complicated method with the numerous of very complicated manipulations like ovarectomy, then fragmentation the ovary into the strips, freezing those strips, defrosting, cultivating them with the special in vitro activating mediums, and autotransplantation into the fallopian tube. And the author of this method, Kawamura, showed that even in patients with premature ovarian insufficiency, the folliculogenesis can be rescued, and even few babies in the world have been born after this method. So cytoplasmatic replacement is a big idea, a great idea in RT, and we are very lucky today because in a few minutes we will listen Professor John Zahn from US, so he has have a great knowledge in this field, and we will get to know something more about this. Method augment is based on the mitochondrial function, which is vital in embryo development. So it was a study showing that there is a possibility to get mitochondria from the own ovarian stem cells that can be located in ovarian cortex, and those mitochondria were replaced to the mature oocyte during ICSI procedure. And sure, all of us Ukrainians are proud that in Ukraine we have 2 babies born after prenuclear transplant clinic on Nadia. So, but Valery Dmitrovich Zukin just showed us that this approach will be indicated to young patients up to 37 years old with a good number of oocytes. So at the end, I would like to conclude that Bologna criteria for poor ovarian responders unfortunately comprised a very heterogeneous population of patients, and we are not able to identify the use of any particular intervention in this population. So Poseidon criteria help us to recognize different ovarian response groups that is crucial for clinical management and interpretation of randomized controlled trials. And concept of low prognosis should be developed in future. We also need to realize that HIPAA response is something very different from poor ovarian response, and we see that there is the evidence that recombinant LH is effective in Poseidon group 1 and Poseidon group 2 and probably in Poseidon group 4. Thank you for attention.
Thank you for your excellent presentation. Я дякую вам за вашу дуже гарну презентацію. Я хочу запропонувати запитання, коли в нас залишиться час в кінці. Thank you. І я хочу